Hey class, this week we're going to do respiratory, which is chapter 45, and I'll have this divided into at least 2 sections. So we're going to look at some of the unique characteristics of the pediatric respiratory system, some things that make them special anatomically and physiologically. And we're going to start looking at some different disease processes that commonly affect children and go from there. So, looking at this slide, what differences do you see as you compare the baby all the way up to the adult? Just looking at the slide. Let's see if we make it bigger a little bit. So, looking at the baby, we've got the little chubby neck rolls here. And then as it goes up to the child, I notice that the neck elongates. So why does that matter? Why would the neck matter when it comes to airway issues in the child? When you're dealing with a short neck as compared to a longer neck, it matters a great deal when it comes to positioning the airway, so that in an effort to have an open airway. And that's the first step, right? In the ABCs is opening the airway. So having the short, fat neck can preclude an open airway. As far as the airway itself, we have a distance here. Look at the same distance in the child, the older child. It's a lot longer. Why would that matter? What if you had to suction a child and they had a trach, not an ET tube with number markings to guide your suction catheter, but an actual tracheostomy where you're basically going down blind when you insert the suction catheter? Having knowledge of your anatomy in that aspect would help you in estimating how far to insert the suction catheter. And of course, it's more complex than that, even when it comes to having any type of artificial airway and knowing how it should go. Let's see, let's back out of the, so as you can tell, even when, as the child grows even more all the way to the adult, the airway, longer and longer, easier and easier to position for the neck for an open airway as compared to that small infant. Yes, the diaphragm also gets larger, but the main things we're looking at here is the length of the airway and the length of the neck. But there's one other big important thing that we need to take note of, and that is the size of the lung space themselves. The adult has many more. When we look up here at the alveoli, the pictures of the alveoli, the adult has many more alveoli than the infant. Look at that. That's huge. And what happens at the level of the alveoli? That's where our gas exchange occurs. And so the significance of this tiny amount of alveoli here and how it gets, gradually gets more and more complex as the child grows to adulthood, the significance of that we're really going to talk about today. On page 1030, there is a section that discusses pediatric airway differences, and I encourage you to review that on page 1030. So pediatric patients have narrow airways. Narrow airways are easily blocked by boogers. So secretions, whether it's slimy secretions, tenacious, goopy, green secretions, or thin, clear secretions that are easily suctioned, regardless, their airways, whether it's their nares or their oropharynx, their nasopharynx, all their their bronchi, their individual bronchus, the individual bronchi, they're all easily blocked by secretions. And they don't know how to blow their nose when they're born. They don't come out knowing how to blow their nose. That's why God created the bulb suction. And that's why we have to make sure that parents are using the bulb suction and understand the importance of that device to the point that it can be life-saving. What does infants are obligate nasal breathers mean? They are born breathing through their nose. They don't know to open their mouth if their nose is blocked by secretions. Do you hear what I'm saying? They do not know to open their mouth if they cannot breathe through their nose. That's a big problem. What if they are stopped up with a cold and it's just clear, thin secretions, but there's so much of it and half of it's dried and crusted all inside their nose. There's so much of it that they can't breathe through their nose. And you put a bottle in their mouth because they're fussy, because they probably just generally don't feel well, considering they have this cold. You put a bottle in their mouth, and then, how are they supposed to breathe? They already don't know, if my nose is stopped up, let me try to open my mouth and breathe. But any chance they had of opening their mouth to breathe, you have just occluded that final chance. At least until they're 2 to 3 months old, they only breathe through their mouth when they cry. That's the only time babies breathe, and they're obligate nasal breathers the rest of the time. Maybe this could last up to 6 months in some children. They may be 6 months old before they know to open their mouth to breathe. And then also the trachea is softer and more flexible in a child. And that basically means that that soft, flexible trachea is more susceptible to laryngospasm, meaning, that kind of cough, 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 cough that they can't control. And they just lose control because of a laryngospasm. So to remind you, we don't tilt the head all the way back when we go to position the airway of a child, but we don't want their chin to be lying on their chest either, because that can preclude the airway. We want the child's nose to be pointing towards the ceiling in a sniffing position. So you just slightly elevate the chin just to where their nose is pointing to the ceiling. So why am I showing you this picture? You're not going to be intubating. No, you're not going to be intubating, but guess who takes care of the child after they get intubated, while they're getting intubated? Pre and post. It's you. So the practitioner comes and intubates the child. I want you to have an idea, not only how to assist, but of what's going on inside of that child's body once a tube is placed. How do you take care of it? And the kind of damage that can be done. So what this person is holding in their hand, the handle, that comes in 2 different sizes, and then there's a metal blade that they push the tongue out of the way with, and they use that blade to visualize the, what is my word? They visualize a lot of things, the larynx, the epiglottis, and all of these things. So it's a lot harder than it looks, but from a view looking in, this is what we see. Let me get my pen here, use my laser pointer. So when he looks in, he sweeps the tongue to the side, he or she sweeps the tongue to the side. The esophagus is down below. Now think about this for a minute. You touch your neck right now. What do you feel when you touch your neck? What's in the front? Trachea, yes, so that's your airway in the front. So if you were laying flat on your back, what is going to be the most anterior? What's on top? The airway. So if I look in your mouth, and I'm trying to look at the hole on top that's leading to your airway, what do I have to make sure I avoid? The hole on bottom. The hole on the bottom is going to be much easier to see. That's the hole that leads to your stomach, the esophagus. We don't want the esophagus. We want the hole on top. And it is hard to visualize the hole on top. Our bodies are created that way. We want food to go down the hole on bottom, the easy hole to access, okay? And so the epiglottis is down here on the bottom. It takes a lot of effort to visualize this hole without breaking teeth as you try to lift the jaw and gain access to that. So the tongue is up here on top. The epiglottis, what it is normally covering the hole to the airway, is here. The tongue is up here. And here, these white lines that are V-shaped, that is the entrance to our trachea. Those white lines are our vocal cords. So you can see by intubating someone, we are sliding a tube through these tender vocal cords, right through this hole. That's our mark. You can see how easily these vocal cords could become damaged and why your patients are hoarse sometimes after they have been extubated or the tube has been removed. So that's what the tube has to go through. Every time the child bucks and kicks and cries, or tries to pull the tube out, or coughs or gags or whatever it may be, when a child is not properly sedated with the tube in place, all of that tissue, that soft, pink, fragile tissue is being damaged. So it is our job to protect the child or any patient from themselves if the tube is in place. Also take note here, what do we have here behind the shoulders and slightly behind the occiput? A blanket roll. You will not intubate a child or obtain a successful open airway without a blanket roll, either behind the occiput or behind the shoulders. Okay, so here's the tube that's going to get put between those vocal cords. We have uncuffed tubes, we have cuffed tubes. It's up to the physician to determine which tube they place. Sometimes they choose to do an uncuffed tube, especially on neonates or premature babies, because once this cuff is inflated, the idea is that extra pressure that is exerted on that fragile pink mucosa could potentially cause necrosis of the mucosa. So it's a give and take on whether or not you use a cuff or you don't. The advantage of using a cuff is that it creates a complete seal where no air can escape. Let's see if I can draw. It's a big if I can draw on this device. If you have, nope, that's not going to work. Let's see. So if you have your airway, that's a wumpy airway, but anyway, and then inside that, this is funny. Oh my, there's our tube, a very wumpy tube. There's our tube inside there, and then you have a cuff that you inflate. Hopefully you get the idea. I don't know how people do this. If you have a cuff, then the air that could have escaped between the tube and the mucosa here, it can't get out. This air, here's your lungs down here, and this air cannot escape. There are times when we want to 100% control the air that goes in and the air that comes out, and we don't want any to escape. So a cuff can make sure that that doesn't happen. Oh man, that's a rough drawing. Also on this tube, we have here a number, This is a 3.5. I know it's blurry, but it doesn't matter. This is where the number is. It's a 3.5 uncuffed ET tube. This part is the section that connects to your vent circuit or your embu bag. And then this is inside the patient. And at this end, it's difficult to see here, but it is a beveled end. Let's see. And then if we zoom in on this picture, you can imagine that this is a number, this is a number, this is a number, and this is a number. So these are centimeter markings that correspond with your catheter, your suction catheter, the same one you practiced with in level 1. And you line that suction catheter up with these numbers. They should match. And that tells you how deep to go when you're suctioning your patient. And here you can see a little bit better the beveled tip on this catheter. This balloon on the outside, in case you're wondering, this attachment is visible hanging out of the patient's mouth, because this is the part that is inside the patient here. I hope you can see my arrow. I really don't know if you can. This is the part that's inside the patient. This is outside the patient. And this cuff will be laying alongside their mouth. And if this balloon here, this is the balloon, if it is inflated on the outside of the patient, then that means it is inflated on the inside of the patient. If this is flat and deflated, then the cuff is deflated. That's the purpose of this. And also, this is where you attach the syringe, just like a catheter. You attach the syringe here and inject it with air to inflate this cuff, thereby inflating this cuff. So this is a great picture because it shows us in an adult, this is our airway. And we have 18, well, let me start here. This is our airway in an adult. We have 20. I'm going to get rid of this pen because I am causing much damage. Wonder what a highlighter would do. Let's try this. An adult airway is 20. It's only slightly better. 20 millimeter airway, okay? When you extubate a patient, you take a tube out. The fact that that tube has been in their airway has caused irritation. You cannot avoid it. That irritation in turn leads to some degree of inflammation. It's expected. When we pull that tube out, we're going to expect 1 millimeter of swelling. We expect that, 1 millimeter of swelling. That leaves us with a diameter of an 18 millimeter airway. So it's only decreased slightly. They have a little bit thicker straw to breathe out of until that swelling goes down, which is why sometimes our patients have a little stridor after extubation. Not much in adults. We really don't see that in adults. But then let's go up here. Let's look at the newborn airway. And now we have, well, now look. So we have a 4 millimeter, not a 20, a 4 millimeter airway on a newborn. They say you can estimate a child or infant's airway size by looking at their pinky finger, FYI. That's not an exact science, but just FYI. This is their airway. You take a tube out. Now they have 1 millimeter of swelling. You have decreased the diameter of their airway by half. Let that sink in, by half. So say we're not dealing with an ET tube in a post-op extubation, although we do get quite a few on the peds floor, infants that have been intubated in the OR. What if this was a patient with croup or some type of respiratory illness that caused upper airway swelling? That's what's going on. They can't breathe because of the swelling in their airway. But this is just really significant. This is a huge difference. The adult goes from 20 millimeters to 18. Not even, a fourth of their airway is lessened. And then the newborn, their airway diameter is cut by half. So we looked at this slide on the last lesson, but just to review, we have supraclavicular, suprasternal. Those are our two types of retractions that primarily represent airway obstruction, but not always, but primarily that's what you'll see with upper airway obstruction. And then we have intercostal between our rib cage, our ribs, substernal below our sternum. Sternal is the sternum itself. Subcostal, where you can see the outline of the lower rib cage. So you have supraclavicular above your clavicles, suprasternal above your sternum, sternal, substernal below your sternum, between your ribs, intercostal, below your ribs, subcostal. And that's pretty much it. So be able to recognize each type of retraction and use those words appropriately. Man, these pizza for infants, did I say that? Wow. These what do you call them? Captions, subtitles, they're a mess. Okay, be able to use them appropriately when you document. So children less than 6 years of age use their diaphragm to breathe, okay? The reason they use their diaphragm to breathe is because these intercostal muscles that we're referring to when we talk about retractions, these muscles are immature. The supraclavicular, the suprasternal, the intercostal, all of these muscles, the thoracic muscles are immature. As adults, we use our thoracic musculature to breathe. We don't belly breathe. Children belly breathe because they're depending on that big muscle called the diaphragm to inhale and exhale and expand their chest. When respiratory distress occurs in a child, the negative pressure that's created by the diaphragm causes the chest wall to be sucked inward, causing the retractions. So that diaphragm being our muscle of force in the child, pulling air in and out, in those weak thoracic muscles, it just sucks those muscles in and reflects as a retraction. Look at page 1029, and it has a picture that shows you the level of bifurcation. Bifurcation is where the trachea splits and becomes the right and left bronchus. Bifurcation of the trachea occurs at the level of the third thoracic vertebra in children compared with T6 in adults. So that just goes back to when we talked about the length of the trachea being important when it comes to suctioning. Then also, like we mentioned, the bronchi and the bronchioles are narrower, just like the nares and the nasopharynx and the oropharynx are narrower, making them high risk for airway obstruction, not only upper, but also lower airway obstruction. So when you have a child that has lower airway obstruction, lower airway, guys, means in the chest, in the lungs. That's the lower airway, in the chest. Upper airway is above the bronchi. Lower airway is below the bronchi. And then we mentioned the smaller numbers of alveoli, which is so important. A newborn has 25 million alveoli. And of those 25 million alveoli, they are not fully developed. Okay, so they're immature. As they grow, the alveoli begin increasing in size. They increase in the complex nature. They become more mature. And by the time they reach adulthood, a person has 300 million alveoli. By adulthood, we have gone from 25 million immature alveoli to 300 million mature alveoli. The problem is children, infants in particular, have an increased oxygen requirement, and we'll get into that in a minute. So it doesn't seem very fair that children need more oxygen, but they have less capacity to contain the oxygen. So because of the smaller number of alveoli, just to make a broad statement, infants are at a higher risk of hypoxemia. And we'll talk about that more in a minute. As far as tidal volume goes, tidal volume being the amount of air the lungs can hold is proportionately similar to that of adolescents and adults. The problem is, this is what I was referring to at the end of the last slide. The metabolic needs of an infant double the requirement of, well, let me say that over. The metabolic needs of an infant demand double the oxygen. So babies need twice as much oxygen as an adult needs, but they have proportionately smaller oxygen reserves. The amount of air they can hold in their lungs is similar proportionately to that of adolescents and adults, but their alveoli aren't there. They only have 25 million compared to 300 million in an adult. So again, they are at high risk of hypoxia. So that is saying that children require double the amount of oxygen on a normal day just to meet the demands of their growing bodies, their metabolic needs, the demands of their growing bodies. The demands increase even further when the child is in respiratory distress. But unfortunately, there are fewer reserves, if any at all. So when you understand that, it helps one understand how a simple respiratory virus can put a toddler in the hospital when it would not put you or I in the hospital. So it's kind of hard to see with that yellow background, but this slide says work of breathing. Work of breathing is more informative in children than their absolute respiratory rate. Think about that. A child can be excited, upset, sad, happy. You know, emotions can affect their respiratory rate. Sucking on a sippy cup can affect their respiratory rate. What tells us something is their work of breathing. This is why we raise the shirt up or take it off when we do our respiratory assessment. Work of breathing in a child reflects the resistance in those small air passages. It reflects the dependence on their diaphragm and the weakness of those thoracic muscles. When we see a kid that's breathing fast and has increased work of breathing, they are making an effort to compensate for a problem. Once that work of breathing diminishes, they most likely are decompensating. What we hope for is the work of breathing diminishes because of the treatments we are doing and the child overall is getting better. So take this slide in context. This is saying a kid that is working really hard to breathe gets no treatment and then starts to not work so hard to breathe. They're just exhausted and they have nothing else to give and they are decompensating. So by now, hopefully you understand every statement on this slide, and we are doing good. And I'm pretty sure you have seen this slide before. It's just reiterating that the work of breathing is what it's all about. We have lungs with little to no reserve. We have airways that can easily be occluded. We have weak thoracic muscles, and we have kids that depend on their diaphragm to breathe because of those weak thoracic muscles. Increased work of breathing is good because it means we have a chance to intervene. If we don't intervene and there is a decrease in that work of breathing, then it's bad. So something that you should do when you make your rounds, especially the very first set of rounds in the morning, as soon as you hit the door, you are assessing for evidence of compromised breathing. That's one of those things that, you know, it's all about that. If you skip the evidence of compromised breathing and go straight to checking your IV site, you could be in some serious trouble. So from the door, you're listening and looking for any kind of breath sounds that you can hear from the door, like bad stridor or audible wheezing. You are looking at the positioning of the child, whether their eyes are open or they're closed. What is their position that they have put themselves in so that they can breathe with ease? You're looking at any extraneous muscle use that's obvious. Also, their skin color, whether there's mottling or cyanosis present, all of those things, pallor, mottling, cyanosis, not just cyanosis, all of those things can reflect compromised breathing. Once you're up close, of course, you're exposing the chest and looking for accessory muscle use. You're listening to your breath sounds. You're also feeling the quality of your pulses. Are they equal? And what is your baseline quality of your cardiac output? That's what you're checking when you're checking your pulses and your capillary refill. Be alert for neurological changes. How are neuro changes evidence of compromised breathing? And you know the answer to that. Which physical findings would be of most concern in an infant with respiratory distress? Tachypnea, mild retractions, wheezing, or grunting? So tachypnea is breathing too fast. Mild retractions, remember we talked about mild, moderate, or severe. So mild, they're just barely there, but they're there, they're just barely there. Wheezing you'll always document as inspiratory or expiratory, and in what lobe. Grunting, what is grunting? Normally, if we were in class, I would say, somebody grunt for me. And if it's a good class, somebody would start making grunting noises. But more often than not, no one says a word and I have to grunt. Something like that. Grunting noises. So the answer is grunting. That would be of most concern in an infant with respiratory distress. They're just about ready to give out, and that inspiratory, expiratory effort to have that oxygen exchange, to get air in, to get air out, is so difficult for them that they're reduced to vocalizing at end expiration. That's your grunt. Grunting is a sign of impending respiratory failure and is very concerning. So before you document grunting, make sure you understand what grunting signifies. So obviously, respiratory distress can lead to respiratory failure. So early recognition of distress and intervention is vital. You can take this mild, moderate, and severe with a grain of salt. You could say someone in mild respiratory distress, you recognize mild distress based on a fast heart rate, a fast respiratory rate, maybe a little diaphoresis, and they're restless. Those could be the initial signs of respiratory failure. Maybe we're starting to go into failure, but it could be labeled mild respiratory distress. Moderate, they've got nasal flaring, they're retracting, they're grunting, they're wheezing, they're very irritable. Sometimes they complain of headaches. I mean, all of these things aren't always present. It's just how some people like to categorize it. I don't ever categorize respiratory distress. Any distress is bad, and it can, if it starts off where it's simply breathing too fast, I mean, honestly, if you said mild respiratory distress and your only qualifications for that were tachypnea, tachycardia, restlessness, and sweating, you could have that just from someone in pain. So I don't put a whole lot into this. If I have a kid with those symptoms that's also retracting and wheezing, then I have no doubt they're in respiratory distress, and I don't waste time trying to decide, is this mild or moderate? Who cares? And then severe, obviously, they quit breathing and they're bradycardic, and you waited way too long and now they're dead. I mean, you have to do something immediately. If you get to severe respiratory distress, imminent respiratory arrest is about to happen. The oxygen deficit is overwhelming at this point. They cannot recover on their own. Their perfusion to their brain is so poor from lack of oxygen that you're fixing to code them, and it's really bad. So, backing up, the first line, early recognition of respiratory distress and intervention is vital, because that is what it leads to. All right. Adventitious breath sounds. Pretty sure you already know these definitions, but just in case you don't, I encourage you to use all of your resources to listen online, any resources you have on Lippincott, anything that I give you to listen and to your breath sounds. But honestly, the best place to practice is in clinical, and compare what you're hearing with other students, with other nurses, and with respiratory therapists. They are your best resource in bouncing off. What do you call this? What is this? I wanted to call it this, but what would you can learn a lot from respiratory therapists. Okay, wheezing, high-pitched sound, typically on expiration, but not always. Sometimes it's both inspiration and expiration. But if you think about what causes wheezing, when you wheeze, there is air trapping going on in the pathophysiology of what's going on in the lungs. Air gets into the lungs and it gets trapped, and it has a hard time getting out. So the alveoli are filled with air that can't get out. And the effort to exhale that air around the secretions or the swelling or whatever it is that is causing the air to become trapped, that effort of the air passing those obstructions is what is causing your noise, your wheezes. So it is important that we document if we hear inspiratory or expiratory wheezes and the location of those wheezes. Typically, they occur in the bronchioles because of obstruction. Like I said, anywhere that you have swelling or secretions causing a blockage. Rales or crackles, when the alveoli become fluid filled, that's when you hear the air passing the fluid, that's what makes the crackling sound. Usually we hear crackles in children with pneumonia. So if they have a right lower lobe pneumonia, we tend to hear crackles right over the location of that pneumonia. They don't have crackles related to heart failure as often as you would hear in an older patient, an adult patient. How often do you assess a patient for crackles or wheezing? How often? Every 4 hours? Well, let me tell you this. If my kid's in the hospital and they're sick enough with their wheezing or their crackling to need to be in the hospital, I would expect someone to come listen to them more than every 4 hours. I would expect that they could deteriorate or else they're improving. And the only way to know which way they're going is for someone to assess them. If you're doing interventions, if the respiratory therapist is providing interventions, before and after every intervention, you should listen. When children reposition themselves, or adults, when they reposition themselves, when they cough, all of these things, it changes the way the breath sounds come across in a lot of cases. So just because you do or don't hear a wheeze in a location or a crackle in a location at 7:30 in the morning doesn't mean you won't hear it at 9:30, especially if it's right before their next treatment is due. If you listen right after a treatment, they sound great, but wait 2 hours and listen again, and you're going to hear a whole different person. So every time you go in the room with a respiratory distress patient, take note of their work of breathing and their breath sounds, and correlate that with what treatments they've had and what activities they've been doing. Okay, so our first illness we're going to talk about today is viral pharyngitis. So viral pharyngitis, what does that mean? That means a sore throat caused by a virus, which is one of the worst sore throats that you can have. Viruses can be caused, sore throats, viral pharyngitis can be caused by rhinovirus, adenovirus, mono, which is Epstein-Barr virus, just lots of different viruses. Parainfluenza, coronavirus, it matters not. Worldwide, viral pharyngitis is one of the most common causes of missed school or work, according to the CDC. For all cases of pediatric pharyngitis, whether it's bacterial or viral in origin, there's one thing that we've got to do to prevent hospitalization. What might that be? We've got to prevent dehydration. Why would a kid with a sore throat get dehydrated? I wish I could talk back. It hurts. They don't want to drink. So when I start talking about all these different viruses, this is an example, if you haven't had clinical yet, this is an example of the viral respiratory panel that we perform on almost every sick kid that gets admitted with an illness. It's a nose swab, a nasal swab. It comes back within a day usually, and it tests for all of these different viruses. There's a bunch of them, and it's either going to say not detected or detected. If your patient is positive for something, then I just ask that you document viral respiratory panel, influenza A detected, or RSV detected. You don't have to list all of the not detected, but you can see we have adenovirus, coronavirus, human metapneumovirus, rhinoenterovirus, the flu viruses, the parainfluenza viruses, RSV. There's just tons of things that are on this, and this is not the exact one that we do at Willis Knighton South, but it is very similar. Just wanted to show you that in case you haven't seen that. And when you go to the doctor and they do a CBC and you have a kid with 104 fevers, looks terrible, won't drink, dehydrated, don't know what's wrong, and the doctor comes back and they say their blood work looks good, it's just a virus. You're like, what do you mean it looks good? The kid looks like death, they look awful, what do you mean it's just a virus? They're so sick. Well, just a virus can make you so sick, and it lasts for 7 to 10 days, and there's no magic cure, and the blood work does normally look normal. And that's what sucks. And there's so many different viruses, and they're not going to test you to see which virus it is in an outpatient setting because it doesn't matter. Most of them cause very similar symptoms, and there's nothing we can do about it. We test the kids in the hospital setting because we know, based on evidence, how each of these viruses are transmitted, and we take care of multiple children who are compromised. We are responsible for not sharing germs among our patients. We need to know if the virus is contact or droplet so that we can make our best effort to not spread these germs among patients. That's why we test in the hospital. Well, from a nursing standpoint, that's why we test. So for example, here are some viruses and a bacteria or two that are transmitted droplet versus contact. So flu is droplet. Adeno, rhino, parvovirus B19, those are some viruses that are droplet. Contact viruses would be metapneumo, adeno, again, is droplet and contact. Parainfluenza viruses are contact, Entero and RSV. So all of that means nothing to you. I get it. I know that I'm speaking gibberish, but let me put it like this. Parainfluenza is what causes croup in most of the cases of croup. We have to wear a gown when we take care of a kid with croup, because if we lean up against the crib and there's sputum or the kid's coughed or whatever it may be that's invisible, that germ is on the crib, and then we wash our hands and we go to the next room and lean up against that crib, there's potential that we could spread that virus. RSV, very, very contagious, lives like for 18 hours on surfaces. It's spread through contact transmission. Very important that we wear a gown on top of our gloves, of course, in those rooms. Whereas the flu is droplet precaution. So that tells us that based on studies, if you're going to catch the flu from someone else, you were probably within a distance of less than 3 feet of that person when they coughed or sneezed. And that's how you caught the flu from them, something along those lines, versus the contact method. So the other things that are listed, Mycoplasma pneumonia, we'll talk about that more. It is an atypical bacteria. It is also droplet. Pertussis is a bacteria, Strep is bacteria, and Hib is bacteria. And we'll get to those in later chapters. Now we're moving on to strep throat, group A strep pharyngitis. You can see the pus pockets, the sores on the back of the throat and the tonsils. The primary concern for pharyngitis in children 2 years of age or older is that group A strep may lead to rheumatic fever. So to prevent that from happening, it is important that we start antibiotics within 9 days of becoming infected. You know, the rapid strep tests are pretty specific. If they are positive, then it's like a 98 to 99% sure thing. The rapid strep tests have a very low false positive result. However, they are only 70% sensitive, which means 30% of the time they're not really negative. So to truly be sure